So good morning and welcome again. This is the second day of this very interesting course on prostatic enucleation. Together with my co-chair, Dr. Bekos, I would like to tell you about the program today. We have 4 very nice cases that will be done by our international experts. So today is the day of action, and I think that we are ready to move to the operating room where Professor Fernando Sanchez Gomez is going to do the first HoLEP case. So the mic is on you, Fernando, and please tell us some words about the case. Good morning.
Okay. So as I gather, this is a healthy man. He has some cardiac arrhythmia, but otherwise healthy, who has a 110 gram prostate. So we're going to start. His meatus was a little tight. It dilated very nicely up to 20. So I will do a small otis to make sure that we don't force the entry. Just very mild otis at the, that's it, to enlarge a little bit the caliber of the urethra.
So this is something that you do every time, Fernando?
No, if the urethra is ample, for example, after catheterization, there is no need, and let's see if we can go in. There it is. I'll show you what the otis does. You see the otis does a little cut. You see that? It's very, very little cut, but it gives the urethra some extra caliber, and I think it minimizes the risk of stricture later on. This part of the urethra is a little bit tight too, so I will use the dilator to open up a little bit. Give me the big dilator, the 20 French. It's not a proper stricture, but we need to enter carefully. Let's put it in. Just go in and put it. Okay. So just to be mild, to be careful, and start. Yeah, it went through. Here, there's no problem, and down here, we find this little area here that is a little bit more tight. Let me focus the camera. Are you seeing the endoscopic view?
We have a very good endoscopic view, yes.
You have it, no? So I'm going to very carefully try to go in as atraumatic as I can. It's not too bad. I think it's elastic, but there we are, going in. Now close to the verumontanum. You can see here the veru and
Yes.
the prostate. There's a bubble inside, I think. Let's see if we can get rid of the bubble. It's funny, this bubble, huh? It's okay. Good. So again, there we are. So this is the urethral orifice on one side and the other side, on the distal face of the bar, and the bladder looks a little bit trabeculated, but nothing special about it. You can see it's a relatively large gland, verumontanum, and as we go out, we're going to see the edge of the sphincter here, huh? Let me focus a little bit better. Let's get the fiber, please. Fiber. The tip of the fiber for me. Beautiful. Thank you. So let's start. We are using Richard Wolf instruments, which are my favorite for HoLEP, and we are using the Moses laser system, Holmium 120 watts. Is it ready? Okay, and so I will start by marking, you see, the limit of the sphincter with the apex. Huh? As we said yesterday, this maneuver, or just setting up the white line, is a good way to protect the sphincter's mucosa. Huh? So I'm going to come up here. We can check again. You see, this is the edge of the sphincter, so we are right at the limit. Here, you shouldn't be shy because it's very, very safe. There won't be any problem with continence. And it's always a pleasure to use Moses because it has enhanced a lot what holmium laser can do, in the sense that we get excellent dissection, and we get excellent hemostasis at the same time. Here, I am entering the plane between the adenoma and the capsule, right? Just following. You can do a little bit of mechanical dissection as well, very gentle to find that you are in the right plane. But I'm quite happy there. So here again, we go to the other side. I like to cut these little fibers here because when we enter this space with the resectoscope later, it's nice if you don't force anything. If you just, cut the mucosa, prepare the entry. So here we will let the laser do its work, both dissecting and coagulating. Here, that looks like a good plane there. So just very gently and very carefully, we are entering the plane, the posterior plane, okay? So if we look back now, we will see that we enter the plane in both sides. Look at the sphincter, it's okay, huh? And now we will cut above the verruc through the frenulum to try to connect both planes posteriorly, huh? This area, it's a little bit fibrous, and I'd rather not do mechanical dissection, but I prefer to do this cutting. So now you see we have the line of dissection. It's a line that we can follow posteriorly, and what you have to do with HoLEP is to position yourself properly. And you see the position of the scope is going to be aligned with the line of dissection. You see, this is my line of dissection. The scope is looking at the line, and you can see anteriorly a little bit of adenoma and posteriorly a little bit of capsule, all right? So this is the way to
Fernando?
Yes?
Is it possible, I mean, for the technical team to have both the endoscopic and the image from outside to see your movements?
Can you do a view from outside to show my hands or to show what I'm doing? Okay, they will try. So basically, you see what we do is we get close with the camera to the line, and you see that by getting close, I'm opening the space a little bit. I'm not pushing. I'm not pushing. I don't want to dissect pushing. I just want to position myself so that we can see the plane. You see, and the fact that the endoscope is almost touching with that region is going to help with the dissection a little bit, because it generates a little bit tension and counter tension, you see, and then when you fire the laser in the middle, you will get some dissection. Here there's not so much tissue. Here this is the entry to the urethra. Let's see if we can open up a little bit more. So very gently and very carefully, we're going to progress to dissect the line. I think it's important to reflect about what we said yesterday. We have the settings of 2 joules and 50 hertz with Moses setting. So Moses has a double pulse that will the initial pulse would mainly open the plane, and the second pulse will travel through the initial bubble and will reach a little bit further. So what we have gotten with Moses and pulse modulation is a much better hemostasis as we go. You see, this is what I call first pass hemostasis. So when you dissect the plane, you get excellent hemostasis of the plane. Then, of course, you have to be aware that the energy settings is not the only determinant of tissue effect. All right. So the distance is important. If I fire too far away from the tissue, nothing happens, because the holmium light energy, it's going to be absorbed by the water. So if you get a little closer, you see you can get this mix of dissection and hemostasis at the same time, which is the ideal one. If you get too close to the tissue, you might make a little hole. So, you have to control the distance. Okay. Now I'm going to put my fiber at 12 o'clock. You can see up here we have the edge of the sphincter. So you see we have to liberate the apex, and I have to start by cutting a little bit deeper into the white line. Let me see if I can focus at a better proximity here, like that. So you see we have to enter this plane down there, but when you do a little bit of deepening of the cut, like that, even cutting on the adenoma a little bit, you will get much better access. So I don't mind cutting here on the adenoma a little bit, but of course I want to look for the proper plane. So here we're going to try to enter the lateral plane. So I'm going to go and enter the lateral plane if I can. And initially I will just want to gain 2 or 3 millimeters upwards, you see, like this. But I'm going to take the dissection progressively towards the bladder neck. You see here, deepening a little bit my dissection. And also this is what I call mobilization of the apex and connect. I want to connect the lines. You see, we had a line posteriorly, and I want to connect the line posteriorly to the line that we are doing laterally. Okay. And here you will notice how we are starting to see a little bit thin capsule. So then, of course, not only the speed of movement is important, but also where you aim your laser. So I'm going to aim a little bit closer to the adenoma so that we don't deepen in the capsule, okay? But now this apex is mobilized a little bit laterally. You see now we have a much better entrance to the lateral plane. But before I continue going up, I don't want to be, you see, inside here dissecting upwards, while the scope is making traction here, you see? I don't want to put traction on the apex, so what I'm going to do is to open the apex first. You see a little bit? I'm cutting on the white region, so I know the mucosa is going to be perfectly okay. And when we have better access, you see, when we have better access, we can go now a little bit further with our dissection, following the plane that we already started, and taking it a little bit more up. But again, I will deepen. I will go towards the bladder neck because I need to mobilize the apex. Mobilize the apex. You see, we want mobilization of the apex to be able to reach the anterior parts without putting too much tension in the sphincter. Regarding the plane, you see, sometimes we see a very beautiful plane. Sometimes we don't see it. But we know how to recognize the plane. You see here, we have a surface that is fibrous, you see, mostly white. We don't see a lot of yellow elements there. The adenoma is going to be more yellow. Maybe I need the table up a little bit. Table up. Raise the table, please. So here you see at the apex level, we are coming towards 12 o'clock area here. This is the 12 o'clock area. A little bit. Okay. Thank you. 12 o'clock area here. We were able to mark our white line here, but we didn't finish all the way towards 12 o'clock. But now, you see, we just have to continue with our dissection anteriorly towards the 12 o'clock 12 o'clock mark here. Brilliant. So now we continue coming up. You can see, for example, this is adenoma. You see, it's yellow. It's yellow. So we have to go out because we want to take all the adenoma out. So we have to explore a little bit further out because we want to reach the anterior-most part of the capsule. Sometimes we play in a very thin, you see, very thin capsules. When you see these big prostates, many times the peripheral zone gets very thin. So we have to be careful, but at the same time, we don't want to play it excessively safe to that, so that we leave adenomatous tissue. All right. Now look at the beautiful line. Yesterday, I showed you the MRI image of a prostate, and you see the line that goes around the adenoma. You can follow it very nicely. It's very uniform usually. So even when we don't see the plane characteristics, when we don't see the beautiful plane, which, you know, not always we can see, we know that we are in the good plane and it's everything is uniform. And if we want to connect with the posterior plane, you see we have this initial line here. So if we want to connect, we can connect. So we don't lose ourselves inside here. Okay, it's just a very simple, the mechanism of an orange. We are just dissecting the orange. But now we have to come to the apex and release this side. So here I think we're going through the right plane here, anteriorly, right plane, anteriorly. Here we are. And it's also important to start developing the anterior line. You see, we did the lateral line. Now the direction of the plane is changing. And if we are able to go a little bit, let's say, on top of the adenoma with the scope, you see, this will make the apex descend. The apex will fall down a little bit on this side. That we are looking now at a little bit easier plane to recognize, I think, up there. It looks good, a little bit. You know, you shouldn't be afraid to see these little aspects, little things, little fibers crossing from side to side. Don't lose track of the line. You see, the line is telling me this is the good direction here. And you see, this is anterior aspect now. Let me focus a little bit better if we can. Here. So you see that with this laser, we don't need to do a lot of hemostasis as we go. This is the 12 o'clock region here, you see. And now we're going to come to the other lobe. This is the other lobe. This is the edge of the sphincter here. You see how the mucosa of the sphincter easily breaks if you're not careful. And if you continue with the dissection, what happens is you detach the mucosa from the sphincter, and then you will have this curtain. So I'm going to avoid the curtain. I'm going to go a little bit here, deepen in the adenoma, into the adenoma, a little bit so we can get access. Initially, I don't mind cutting here because I'm going to go to the good plane. Look, the cut is here, you see? It allows me to individualize the sphincter from the apex of the prostate a little bit, and then we can go to the good plane. And here again, I'm going to repeat what I did on the other side. 2-3 millimeters up, going up and down like this to try to mobilize and connect the plane with the dissection plane we had before. Let's see here where we are. This is looking good, but this is adenoma. You see here we have to go around this adenoma, I think. Carefully.
Dr. Sanchez, how important it is to have absolutely
It's
the
like
right
a nodule
plane?
there that we want to remove if we can. So again, let's try to be systematic. Systematic is good. So here I am trying to go from the posterior plane to the lateral plane. Let's continue. You see, I saw that nodule going into the capsule, and I think you have to follow these nodules. All the yellow tissue like that, you see, this is normally, this is adenoma, huh? But here the capsule looks a little bit thin, so we have to be careful. Probably, yeah. That's slightly deep. Let's see. Yeah, we have to find out. Sometimes we find out as we go. So here, let's try to come up some more millimeters. It's difficult to keep the focus always okay, because sometimes we are a little bit close to the tissue. Sometimes we separate, and at this distance, I think it's not so easy to keep the focus right all the time. But here, what I'm trying is to continue this dissection at the bottom here, mobilize the apex and connect with the line that we had before. Here, you see, this is connected now. Let's see if I can focus at this distance so we can see more detail. This is looking good. This is yellow, huh? This yellow stuff is usually adenoma. So very slowly we have to, I mean, in the philosophy of HoLEP, if you try to make sure that every minute you move forward, you do something that makes the case better, then sometimes we're going to be very, very fast with the procedure. Huh? So here, so far, I think so good. We want to remove all the yellow stuff, but at the same time, we want to keep inside the prostate. Huh? We don't want to do a bad perforation. And the way to keep in the plane is to be very sensitive to where you're aiming. Huh? The aiming is very important. So here, we're also coming up. We are connecting this line with the posterior line here, you see. We can follow this line, and that will help us orient ourselves really well. Everything we see in the plane is fibrous. You know, it looks like capsule. And here we're coming up. You see towards 12 o'clock on the apex. Here we are. This is apical tissue here. This is what we marked. So we are doing well. We want to come up here and release the apex before we continue our dissection. Yeah, this is good. This is 12 o'clock region. And now we continue our dissection upwards, trying to go from the lateral plane now to the anterior plane.
So, Fernando?
Yes, go ahead.
So, if you had a big middle lobe, would you change your approach, or this unblock technique is fits for every prostate?
Yes, you can do unblock in any prostate. We don't care about middle lobes. You see, I think the middle lobe is a problem when you do the ThuLEP technique, in the sense that sometimes big middle lobes, demand to do very big incisions. Here, we don't care about middle lobes. This technique is particularly good, when you have to do a redo case. Yesterday, we saw a video from, I think it was Vincent, showing a prostate after TORP or something like that. And sometimes you cannot even go in the bladder, So if you start your dissection at the apex, you don't need to go in the bladder at the beginning. You can just start and go. Huh? So middle lobe is not a problem. So here you see everything is starting to look much better. This is the direction of the plane going anterior. But as I told you, I don't want to force things here. So I will come out, you see, to see where we are, and to make sure that we cut the tissue in the white region. Here, this is white. Let's cut here, so we don't force the entry to the apex. Huh? This is a horizontal incision below the sphincter, so we are quite safe. The thing is, when you see HoLEP one time, You might be lucky and see a very beautiful case where everything is clear and everything goes really well. And then you have the impression that HoLEP is a piece of cake. And then when you see a very difficult case, then you might, have the impression that it's a very difficult operation. But, the truth is in between. Sometimes we see very easy cases, very easy planes. Sometimes we see somewhat difficult cases. So at the end, that's why I recommend people to see many cases, because when you see many cases, you will understand the basics of this procedure. Let's see what we have here. Here we have the other side. Maybe some vessel was bleeding, so I will clear the field a little bit, because when you fire the holmium, these bubbles and this mechanical effect of the holmium will clean up the. This is the urethra. Let me see where we are. This is belonging to the sphincter here. So the 12 o'clock approach sometimes is a little bit tricky. Let's see if we can connect anteriorly. The idea of this approach is that when you have a nice, let me see if I can show you. When you have a nice understanding where is the plane going up here, you see, we can approach let's say the 12 o'clock area carefully from both sides. Sometimes I manage to show it beautifully, sometimes it's not so easy. This is all anterior plane. You see here, there is some attachment anteriorly. So it's a white attachment, so probably we should be cutting through it like that. Let me see. There we are. Sometimes this 12 o'clock region is a little bit tricky. Here's the other side. You see here, we're coming towards the other side. So we just have to connect one side with the other side, go like this. Try to cut the most distal aspect first. And we're nearly connected anteriorly. I don't know if I can show you better. Here we are, coming up. This is a 12 o'clock attachment. And now we should be able to cut this little bit of tissue here. And then I think we would be connected anteriorly. This is the end of the, let's say, early apical liberation. What I have tried is to go around the adenoma, and to approach the 12 o'clock area very carefully. Here, you see now we are able to connect one side with the other side. And now, from this moment forward, the sphincter is totally released. It's totally free from traction. It will close around the endoscope, and it will accompany the endoscope on its movements, but it's not being distended or anything. And now we enter in this phase that I say it's easier, because you see we have a line around the adenoma. You could imagine the orange. We are peeling the orange. This is the line that we see on the MRI. It's very uniform. And we can follow this line all the way because we were careful to connect the lines. You see the posterior line connected to the lateral line. The lateral line connects to the anterior line. And then we just have to go around. Let the holmium do its work of looking for the plane, you see. Try to aim your laser. We saw 4 determinants of laser effect on the tissue. The first determinant is the settings of the machine. The second determinant is the distance at which you fire. It's not, if I fire too far, nothing happens. If I get closer, you start seeing the effect. So you have to check. It's sometimes it's very subtle, just less than a millimeter difference. So you want to achieve an effect that will give you some dissection. But you see, if you fire against a tissue like that and there's no movement, there's no dissection. So you have to combine the right distance with the movement. And then you can move very slowly like this, or you can move faster. You could go even much faster sometimes. So what you have to start understanding, and what you have to do when you do HoLEP, is to start trying a little bit. Let's try this distance, let's try the speed, and see how it goes. I would say probably the ideal speed of movement is that movement that gives you good dissection, but at the same time gives you good hemostasis, okay? And then, of course, it's the aiming, you know. If this is our line, let me show you the line of dissection. This is the line of dissection here. If I fire outside of the line, I'm going to go in the capsule, you see? That's not good. If I fire against the line, sometimes, especially at the beginning of the procedure, it's going to be okay. But when the planes start changing direction, you know, this would be against the capsule, in the line, and you have to get closer to the tissue. You have to get closer because you want the energy to disrupt the fibers that hold the capsule and the adenoma together, but you don't want to deepen in the capsule. Huh? So here we are coming now towards the bladder. Huh? You can see as we dissect anteriorly, you start seeing this pattern of circular fibers here. You see circular fibers of the bladder neck and vertical fibers here. So when you fire here, you enter the bladder, okay? So the vertical fibers under the circular fibers is a very pathognomonic sign that you are entering the bladder. So here you see, here we are, now cutting the bladder neck. So, you know, it's funny that the anterior commissure is here below me. And if you could see the outside, you see that I am at 12 o'clock, but I'm not pushing my scope down. You know, when you have to do a 3-lobe HoLEP, in order to reach the 12 o'clock, you have to push your scope down and angulate the scope a lot. Here, what's happening is the adenoma has been mobilized. You know, now it moves, and it is compressed by my scope. So I don't need to force too much. So in this technique, instead of taking the scope to places, what you do is you mobilize the prostate so it is not so difficult to get to those places. Look, this is the beautiful plane. Sometimes we see, you see, the beautiful plane. Of course, with this kind of energy, sometimes when you coagulate the tissues, you realize that the beauty of this plane is no longer visible. You see, every time I fire, it's getting coagulated. That's why you cannot base your enucleation in watching this plane, because you're going to be spoiling the plane all the time. So you have to recognize the plane by other factors, you know, like the fibrosity of the plane, the smoothness of the plane, the many ways to know that we are in the good plane. Huh? And also, I would say that the color is important. As I said to you before, the capsule is more white and the adenoma is more yellow. So that gives you sometimes, you see, yellow, white. Huh? So it's very subtle, but it helps a lot. And here what I'm doing is I'm following my line of dissection here. You see we have the posterior line of dissection here, and it has to connect. If you can picture the MRI image in this region here below the adenoma, when it turns from the posterior plane towards the lateral plane, this is probably the wider area. And sometimes going from here to up is a little bit tricky because the angle is quite steep. So here you see how my fiber is now very close to the adenoma. I don't want the energy to perforate the capsule when the angles are changing and there's a very thin plane. This is yellow. You see, it looks like an adenomatous nodule, you see? So I have to detach it from the posterior capsule that looks a little bit thin. So carefully, but we will try to take it out if we can. That looks somewhat yellow as well. Let's see. You see, this is a very, very thin plane down there. But we try to take all the yellow with us. Huh? Good. So let's come now up here. This is bladder neck region. You see here we have to go in the bladder and check the position of the UO. So we are quite far. It's looking good. And many times when we have these sides already done, the only attachment remaining is the 6 o'clock attachment. You see here I can cut the mucosa of the trigon a little bit. So in this side we have a nice bladder neck. If we go to the other side, let's see how it's looking. Maybe we didn't cut too much here. So this is bladder neck. We have to go down also. Bladder neck. You see, that's looking good. And here at this level, I would go in again to check the UO. It's quite far, so you see now we have the adenoma almost hanging from the 6 o'clock region. The case is nearly finished, but this is sometimes a tricky part. So because of course when we do en bloc we have many advantages. You have seen the excellent irrigation all the time. We could see perfectly all the time. The excellent orientation, we don't have, we're going from the apex to the bladder neck. We are pursuing always a forward, dissection. We don't have to go back, check the incision, detect landmarks. So it's much more simple concept than the ThuLEP technique. And but of course there's some disadvantages, and sometimes the end, this posterior dissection is a little bit tricky. You have to start gaining millimeters. 1 millimeter more of dissection will help you a lot because it will facilitate moving forward. So here we want to be careful, especially the capsule here is very thin. So we have to go from side to side. You see, gain a little bit more dissection, 1 millimeter more, 2 millimeters more, will mobilize the adenoma even further, and then we will be able to continue. This is what I thought could be a little bit of adenoma. In these difficult parts, when you see adenoma in a very thin capsule, you can also use the vaporization effect of the laser to take that tissue out or to destroy that tissue. But here we are almost done. Now this is an attachment. Let's try to cross towards the other side very carefully, aiming the laser towards the side of the adenoma. We don't want to perforate in the capsule. And here, let's see where we are here. You see, it's a very little by little dissection at the end, and I think this is almost mobilized completely. Okay, so one thing we can try is to get under, you see the right lobe, you lift the adenoma, and then you push the adenoma. So one of the lobes, you see, this is the prostatic urethra, this is the bladder neck, and this is the lobe already trying to go in the bladder, you see? So when you flip the adenoma like that, what happens is that this side opens even more, so we can reach much better here to finish, you see? So now we will finish this final attachment. We will finish this final attachment. We have much better access now to check how it's looking. Look at how smoothly the energy can be used. If you separate the fiber a little bit, you can reach a moment where there is a very mild cutting or dissecting effect, very good hemostasis, but it's not disruptive. So here you see, now we can see the last 6 o'clock attachment here. Now everything is nearly released. So I think we will finish with this. This is now the last attachment at 6 o'clock, and the enucleation is finished. So in order to push, there's a vessel somewhere. Let's get some hemostasis while the adenoma is still. This is too thin, too small. I have used the setting of 1 joule and 30 with a long pulse for hemostasis. It works really well. It's a little bit slow. Let's see. Sometimes it's just one vessel going. You see, the quality of hemostasis is quite good. after the first pass. No, maybe there is some vessel that we can check in a moment.
Fernando?
Yes, go ahead.
So you made it look very easy, but I don't know if this is the case, because it was a very impressive demonstration of the enucleation. And also we are very impressed by the clean incision, so we don't have any charring.
Yes, holmium doesn't produce charring. Well, it's more like not an effect that is for the holmium. It's the pulsed lasers. Pulsed lasers deliver energy, but then when the pulse stops, there's some relaxation of the temperature, and so they don't heat so much. But there was a question in the operating room. What was the question? For coagulation.
Yes. Also for our online participants,
They are
please,
asking me here.
yes, please feel free to send your questions. Go ahead, Fernando.
Yeah, there is. Let me answer the question that they made here. They're telling me if I use the same set or different settings depending on if I have to coagulate an artery or a vein, and really, no, you have to try. Sometimes you're very lucky with coagulation. One of the aspects that you see, the fiber doesn't degrade a lot with Moses. This is a big advantage because the profile of the beam is very good. Sometimes when you work with a classic holmium, you find that the laser doesn't coagulate well, no? And you think, what's going on, no? And the thing is that the beam is a little bit damaged, and it's not coagulating properly because the fiber is very degraded. So when the light comes, instead of emitting a proper beam, it emits a very, very bad beam, and the coagulation effect is altered. So I try to coagulate, initially probably if my pedal is in the let's say dissection setting like now, you see, you can also coagulate with that. The only thing you have to do is to separate yourself a little bit more from the tissue. But when you are coagulating in a very thin capsule, sometimes if you get a little bit close, you see it could be disruptive. So if it makes you a little bit afraid of using the high power at bigger distance, you can just switch the pedal, and then you get a much smoother effect. You see, it's coagulating, but it's not so aggressive with the tissue. Okay, so now we're going to flip the adenoma into the bladder completely. We will check the hemostasis later as well, but instead of pushing this side towards the left of the screen, I'm going to push it also towards the right, you see? And you see how easily it goes into the bladder. Many people think that with en bloc, you cannot push the adenoma in the bladder when it's big, but it's a matter of rotating the adenoma, no? So now I'm going to spend some minutes doing hemostasis until we have a very, very good view. Let's check again. This mucosa broke a little bit, but the UO should be perfectly okay somewhere here. Let's see. This is the one, and this is the other one. Here there was some mucosal detachment that could cause a little bit of bleeding during morcellation. So we have to check not only the fossa, but also the mucosal edge, because one of the bad things of holmium is that when it cuts the mucosa, it's a very explosive cut, and that's the mucosa doesn't like it very much, and it tends to bleed a little bit. Often we leave open vessels like that. So one of the things that can give you a hard time during morcellation is that you didn't coagulate the mucosal vessels, and then you don't see. So yeah, we have to check. There's a bleeder here, you see. Sometimes you have to spend some minutes. Of course, what we saw with Moses is that the time we spend doing coagulation is much less than before, because the initial coagulation is more effective. No, let's see. We have some apical bleeder here that is causing most of the trouble, I think. So I don't know how long it took to do the enucleation. Of course, it's a didactic case, and usually with didactic cases, we go a little bit slower. But, for many people, holmium laser enucleation is a very, very difficult technique. It's a very long technique. So many people think that this takes hours to perform. Many people have the idea that holmium laser is an operation that can suddenly go very bad because you can have a problem, you can have a perforation, you can have a morcellation accident. And the truth is that it's no longer taking so long because of the good hemostatic properties of the new lasers, the better and the technique. Also, I think en bloc is faster than ThuLEP techniques usually. And also, it's a very technical technique. So instead of being anxious when you do your HoLEPs, you have to be very calm and very relaxed and just tackle the problems you find technically. We are starting to see better. Let's come out and see what's going on here. This is the sphincteric area. There's a little bit of a nick here in the mucosa, but because of the traction. But I think the edge of the sphincter is here, so it's going to be fine. I'm sure it's going to be fine. We don't see almost ever stress incontinence after this procedure. Sometimes, the dissection movements and produce a little bit of ischemia in the region. But the fact that we mark this initial white line protects the sphincter function really, really well. And it's not the same, when you have a longitudinal nick in the mucosa, when the sphincter closes, this is the ejaculatory ducts, you see? Ejaculatory ducts. So that's why we will see that he has a retrograde ejaculation. And then I think we're almost ready to go to
so talking about ejaculation, how easy is to preserve ejaculation with these preserving techniques?
Well, I think for ejaculation preservation with holmium in the big glands is not easy, and it's not very predictable. You can try. Often you can get a good result on a patient who tells you he can ejaculate, but often you can't. There is a paper out from a group doing thulium preservation with enucleation, ThuLEP plus preservation of ejaculation, and they allow to have 87% of ejaculation preservation. What they have to do is they have to protect the veru, the region. So they leave apical tissue here, and they are very careful to try to preserve the ejaculatory ducts and some of the paramontanal tissue, to preserve. But it's not very predictable, I would say, in the very large glands. I think we have much better chances of preserving ejaculation when you do smaller glands. So, but I think probably thulium, the cutting of thulium is much more consistent than the cutting of holmium. So if you want to, let's say, make a decision of what you're going to take out and what you're going to let in the prostate, when you have that idea of what you want to preserve, the thulium laser allows you much better to do. So I wouldn't be surprised if we start to see papers of thulium guys achieving good preservation rather than holmium guys, because this explosive nature is very good to dissect the plane when you are in the plane, but it's not so good to cut the adenoma in the middle, So here we are. I think we have good hemostasis. Now we're going to move on to the morcellation. So the fiber is for you. You can now give me this instrument and I will change it here. Can you dry this with a hose first? Just in case there's some water. Just dry around and inside. Okay. Beautiful. Now help me like that. Beautiful. Pull hard. You need to pull hard like that. Beautiful. Now I will connect the light. get the morcellator ready. Let me just, the plastic is in the middle. Okay. Now, I'll take the water. Let me do it for you. I will release this, and you just have to remove it. Okay. So now I'm changing the instrument. Here's the morcellator pedal. This is the morcellator going in. Now, to morcellate, I'm going to position myself here in the bladder neck, you see. I'll go under the piece and lift the tip and lower my hands, okay? It seems to be morcellating okay. So the idea of morcellation is, many people are very afraid to use the morcellator. So what they tend to do is they tend to keep it like this, very close to the lens, because this way they think it's less dangerous. But you see that most of the screen is covered by the adenoma. So if you put the blade a little bit inside like that, what you get is, of course, the adenoma above, you see, the morcellator blade below, and in both sides of the morcellator, there's a black triangle. And this black triangle is your safety, let's say, check. If we go closer to the bladder, you see the black triangle at some moment is going to show us that it's getting more pink or more white. Huh? So if you see this pitch black color around the blades, we are okay. We are far away from the bladder wall. You see, most enucleators use 2 inflow sets, with 4 bags to morcellate, because, of course, they think if you put more water in, there is less chances of accidents and so on. You know that all the outflow of water in this moment is happening from the tip of the morcellator. So all the outflows are closed, and it's only the tip by the effect of this aspiration that is taking out water. Okay, but I love simplicity, and I think that HoLEP is probably too complicated already, in the sense that if you have to put a second set, more bags, change more bags, it becomes a little bit cumbersome, difficult, or So I use only 1 set. But of course, I am very careful to observe the efficiency of morcellation, because I have observed that when you morcellate the tissue, and if you look at the blade, you see that most of the time the blade is covered with tissue. You see the mouth of the morcellator is covered with tissue. That means that the tissue is constantly blocking the outflow of water, you see. So you are sucking water out, of course, but not too much. So here you see it wants to go from one lobe to the other lobe. So what I mean is, if you have efficient morcellation, usually the bladder will remain full. But if the morcellation is not very efficient, like when it gets at the end, sometimes we get these nodules, the beach balls, and then you see the blade rotate like this, sucking water all the time. This, of course, you have to stop that, because that will empty the bladder very fast. So it's a balance. You have to check the balance. You have the possibility of palpating the bladder to see if it's full. In this case, it's very full. So simplicity is good, and it makes the procedure faster, easier, less cumbersome.
Dr. Sanders,
Yes.
do you have, in the cases that there are a lot of stones, do you have any special precautions when you morcellate?
Yeah, well, stones can damage the morcellator blades a little bit, and they can block the motor, So sometimes when we have to do prostates with lithiasis prostatitis, that where the stones are included in the tissue, sometimes it's a problem for morcellation. It's not very common, Of course, when you do big stones before enucleation, you have to clear the bladder so there are not too many remaining stones fragments, because this could damage the morcellator. The Piranha has really led the new generation of fast morcellators, and it's a joy because you can take out around 10 grams per minute. So if this adenoma is, 90, 100 grams, 80, something like that, it should take only a little bit, only some minutes. It's getting full? No. So also morcellation has cut down the times a lot, and to me is the major paradigm changer, because before, I think to morcellate an antigram prostate would take 1 hour and a half or something, so 1 hour. So it was a tough enucleation, and then it was a tough morcellation. Now, with these new lasers that have these excellent hemostatic properties, there's a second generation of holmiums, the pulse-modulated holmiums like Moses and the Quanta Virtual Basket. And there is a second generation of thuliums that would include the pulsed thulium lasers and the TFL, the thulium fiber laser. These thuliums have much lower peak power than holmium, and that means that when the pulse is emitted, there is less peak energy, and that is what produces the bubble and the mechanical dissection effect. Okay, let's wait until it doesn't. Okay, let's change. So stop. Yeah, take it out. Maybe you can also take out the tissue from the basket if you want. We are changing the bucket. This is one of the problems with. So where was I? Okay, so as I said, holmium lasers have a high peak power. High peak power produces a blast that will dissect the plane mechanically. So that's why I just point the laser towards the line, and the holmium laser is going to open the plane following the path of least resistance, which is the interface between adenoma and capsule. But when we use thulium lasers and the thulium fiber, what happens is the peak power is not so big. So you have less dissection effect and a more cutting effect. So I tend to think of the pulses from holmium like a little scissor opening, So you're opening the scissor around the plane. And I tend to think of the thulium lasers as a surgical knife, as a very, we don't have water. Very, how do you say that? Sharp edge knife. So with thulium, you can easily lose the plane, whereas with holmium, you can keep in the plane much easier. But the second generation thulium lasers offer an excellent hemostasis. You see, often when we have reduced the adenoma, we can start bringing it to the fossa, you see? So you can do morcellation inside the fossa. And often it's a good idea because the morcellator preferentially eats the tissue that is softer, and nodular hyperplasia of the prostate, some of the nodules are quite fibrotic. So there's not the component of glands in the nodule is not so big, and it's more like a fibroma. So the tendency is that the morcellator will eat the soft tissue first, and then it will try to go and eat the tougher tissue, which is left for the end. So often when that happens, the morcellator has trouble chewing this harder tissue, and the piece goes away from the morcellator more often. So if you keep everything inside the fossa, you see I'm totally immobile. I'm not moving myself. I know I am in a safe spot, And you see the morcellation is happening very nicely. Of course, the visibility got a little bit worse because there must be some oozing vessel in the fossa. But I think here's fossa. That's the last, I think, remaining piece. Let's see how it goes. It's a big one, eh? It's a big prostate. So I hope you enjoyed. I would push you to try to learn HoLEP. You know, it's an effort and it needs some commitment. You will need to travel and watch. You know, you will need to make an arrangement with people in your country who already do HoLEP so they can help you. But it's really worth it. It becomes a very easy operation when you have done a number of cases. You feel very comfortable. You feel very relaxed, and it's like a superpower. You know, you can handle these men with very large glands. They come to you looking for a solution for their problem, and the next day after the operation, they go home without a catheter, and they can't believe how well they are. You know, and that's almost the end. There's some fragments in the fossa. Let's see. Sometimes clot will form in the fossa because, despite the quality of hemostasis, there is some oozing vessel from the mucosa. Also, the morcellator set does not irrigate properly. You know, there's inflow of water, there's outflow, but there's not very good irrigation. So I think we finished. Now we're coming out, and let's put a catheter. Thank you. Look at the flow. So we finished. Try to learn HoLEP because it's a game changer, and you'll have a lot of happy patients and more patients. It's a lot of fun as well. Everything went really well, I think. Good, so I hope you enjoyed. Is there any question from the floor?
Actually, thank you very much, Fernando. It was really a very impressive demonstration, and I think that you deserve a big applause from the audience here. And I'm pretty sure that also the online participants would like to congratulate you. So there's a question about, tell us about the low and high power HoLEP, because there is, again, a discussion about that. So what is your personal opinion on that?
So we put 40, no? Yes. Low power. Well, as I told you before, the settings are not so important because the surgeon plays a very important role in the operation. So if you use a low power, you're going to need to do more passes to get a good coagulation and probably a good dissection. So with a high power, the microphone, sorry. With a high power laser, maybe you pass less often, you know. So the fact that the energy coming from the fiber comes with a lower power does have nothing to do with how much energy the tissue is going to receive at the end. And you know, two different surgeons, maybe one with a high power laser and another with a low power laser, will deliver a similar amount of energy to do the dissection, to do the job, and to do the coagulation. So I don't think it is there's any advantage on using low power. I have used low power and I have used high power, and I have to say I prefer high power because high power is faster, hemostasis is easier, and I think you know, it's not a mathematical thing. Low power will give you less dysuria, and high power will give you more. No, just so yeah. I worked with low power, and I suffered a lot to coagulate the big vessels. You know, sometimes you have to face difficult cases. So I would recommend you to use high power. I think this was something that Scofone, let's say, promoted. But I think not anymore.
Well, I would also tell something about low power. That's what we are using actually. And in fact, after the operation, almost always we need to coagulate with monopolar or bipolar, so it's systematic. But now with high power, you don't need this step, and it's much quicker. And I'm not sure that the irritation symptoms are more with high power than low power.
So, Fernando, please,
Yes.
could you
Just leave it,
summarize
sir.
the take-home messages for those who want to start with HoLEP?
Well, definitely, if you don't do HoLEP in your hospital, you need to make a commitment to learn. Watch many videos, go to visit centers of excellence, and you will then discuss it with your manager. Look at the investment you have to do carefully, but yeah, you have to do it nowadays. This is the moment, and I'll tell you, there's an explosion of centers in the world adopting successfully HoLEP. Once they become, let's say, proficient with it, they are absolute enthusiasts, and they promote it all the time, and they brag about it. So, but you shouldn't be crazy like we were in the past. Many centers try to do HoLEP with very little experience, and they had trouble. So learn properly, get a mentor, try to find a scheme so that someone with experience come to help you several times, not just one. And then, of course, you will be able to learn. It's okay. I would wait a little bit. Yeah, it's not so bad. It's irrigating.
A bit of traction, yeah. It's okay.
Yeah, it will settle. Good. So we're moving on to the next case, I think. Morning.
Thank you very much.
Was the
Thank you
dinner
really
yesterday?
very much.
Huh?
It was.
So, Andreas, we are moving to the next case
Yeah.
in
Sorry.
30 minutes. So there is a break now.
There's a break. Brilliant. I think it's fine. No need to traction or anything. Just let it settle down. It was good hemostasis. It will just the first 2 minutes. It's a little bit more red, and then it gets better. So I hope he will be okay. Let me get my phone number so you can tell me, or if there's anything that we can discuss, or any trouble you want to discuss.
Do you think there are some more dangerous zones in order of capsule perforation with this technique?
Typically, it's the trigon. The trigon. Either the trigon. But very often we go a little bit deep there. Here, that is a little bit like that. But you do an ultrasound on this, no problem. There's no extravasation. If there is a little extravasation, it's no problem. The next morning we take the catheter out. They're fine. When you are an experienced TURP surgeon, sometimes you see the capsule, you see deep areas. You don't care. It really doesn't matter. So this is not more dangerous than TURP.
If you recognize it,
It's really, we do 5 cases in one afternoon. So last week I did 300 grams, 200 grams, 140, and then a redo case in the same.
So